So what I want us to all focus on are the solutions to all the challenges that Brian just laid out. I don't want anyone to walk out of here feeling a burden. I want us all to leave feeling inspired that we found new friends and colleagues with whom we can partner to break down these barriers. And if you don't feel that way at the end, come find Melissa and tell her all about it. She wants to hear directly from you. And so our first panel, of course, has solutions in its title. And it's called Solutions to Structural Racism in the Healthcare System. At Pfizer, we have many colleague resource groups, and we have one for our Black and African American colleagues. And earlier this year, I heard from Dayna Matthew, and I said, she has got to be at this summit, and I'm so honored that she joins us here to lead our next panel. Dayna Matthew is a nationally recognized lawyer and legal scholar with over three decades of industry and academic experience. And she's the first woman to lead GW Law. She's a health expert in equity and public health policy with a passion for public service. She is going to tell you her narrative about how she came to this work and how she saw it impact her own life and those of her family members. And she has an esteemed panel of experts joining her as well. So without further ado, Dean Matthew, welcome.
So I want to tell you that the privilege of being here is overwhelming me, but I will say that echoing Dr. Smedley's focus on inaction, we are not going to stand on ceremony. I want to be clear that the name of this panel has structural racism in it. Racism, we are going to talk about structural racism. We are going to talk about dismantling it. There is a beautiful brochure here that has all of the bios so that you can hear about the degrees and the accomplishments of our esteemed panelist. But just as Nisha's introduction suggested, we are not going to introduce ourselves with a list of our accomplishments. We're going to introduce ourselves by telling you the story, the narrative of what brought us to this important work of dismantling structural racism. So I'll start just to get the room a little bit warm. I am here because my parents died early as a result of structural racism. If their story were unique, it would not bear your attention. But my father died at 48, and my mother died younger than I am today, and you know I'm not going to tell you what that is. But both of them died early because my father worked 3 jobs, my mother another 2, so that I could sit here before you and be introduced as the dean of the university's law school. The only way they could do that was because the structures of my South Bronx neighborhood required them to work 4 jobs in order to get a living wage. Moreover, the structures of my South Bronx neighborhood required that they got me out of the South Bronx in order to be educated, or I wouldn't be sitting here today. Those of my peers who stayed in the South Bronx for middle school are either dead, drugged, or have criminal records. This is not a unique story, as I've said. The air I breathed as a child in the South Bronx, the water I drank as a child in the South Bronx, the education, the food, every one of the institutions that affected my life contributed to my family's early death, and that my neighborhood includes Black and brown people who die quicker and live sicker. That's what's brought me to the work. Now, to introduce you to the person I call Pfizer's physician, you'll see that she is the chief medical officer of the entire organization, that she is responsible for the worldwide medical and safety of the entire organization, that she is on leave from Stanford University, where she's a tenured member of the medical school faculty. I'd like to ask you, Dr. Aida Habtezion, what is the narrative that brings you to this work?
Thank you. So what brings me here, I just want to put it out there that I'm not a health equity expert. I'm humbled, in fact, to be amongst you, but it is something that I'm super passionate about. And what brings me here is that actually the patients that I took care of for the many years that I served as a faculty. In fact, I was a practicing physician until the end of 2020, in the midst and the height of the pandemic. So these are the patients, those stories, those disparities that really never go away, regardless of what disease, what they were facing. And those are still, in fact, in my role currently, those are the people that I think about. So it is a professional journey for me, and there are many examples, and I'm sure we'll try to discuss those. And from a personal perspective, I was born and raised in sub-Saharan Africa, in East Africa, during the war times, 30-year war history. So I was a refugee who was displaced from my family when I was a teenager, a minor, together with my older brother. So it's a story of an African woman or a girl at that time, and a refugee and an immigrant. So it's also that community that brings me here, all those barriers that population, that community from which I identify myself. And sometimes because I'm a physician, because of where I am, I'm called to usually ask and help those patients. So it's always, for me, the focus is always where that, regardless of what my role might be, is that of a physician. Even as a scientist, when I'm thinking about my own science, I try to think, how will this impact those patients? How will it be, even as an educator, as a professor, how would that impact our workforce, as we heard, the next generation, and how we're going to impact? So those are the stories that really bring me in. It's something that I'm super passionate, and this is why I'm here.
So a physician scientist. Next, I want to introduce you to Dr. Uché Blackstone, a physician advocate. Blackstock, excuse me, a physician advocate. So you'll see that she is not only nationally known as the leader in bias and racism in healthcare, but she's the founder and CEO of an organization called Advancing Health Equity. You are dedicated to dismantling racism. Would you talk to us a little bit about the narrative that brings you to this work?
Sure. Thank you, Dean Matthew, and hello, everyone. And I'm so happy to be here and see some of my friends here that I've only known virtually over the last few years. So the reason why I'm here and why I care so deeply about this issue is it's very personal. I am the daughter of Dr. Dale Blackstock. That was my mother. To be able to say that I am a second-generation Black woman physician is something that is very, very rare. I'm proud of it, but I'm not proud that I have to say that. My mother was a little Black girl from Brooklyn. She grew up in poverty. To single mother, she had 5 siblings. And along the way, through fortune, through work ethic, through luck, and through professors at Brooklyn College who saw potential in her, she was encouraged to apply to medical school. It was something that she had never considered because her teachers in her Catholic elementary school told her that she could never be a doctor. And she ended up applying to medical school and getting accepted to all of her medical schools and ended up at Harvard Medical School. And so she was in class with classmates whose parents were had won the Nobel Prize in chemistry and who had authored some of the books that they were using. So she was definitely a fish out of water. But she used that experience to come back to New York City for her training and to work in this very, very same neighborhood that she grew up in, taking care of her neighbors and family members. And that is who I have modeled my life after. My twin sister and I, who's also a physician, we lost her when we were 19 years old. She was only 47 years old to acute myelogenous leukemia, but we continue her work and we celebrate her legacy by working on these issues and trying to advance health equity.
Thank you so much. And I now want to welcome the other lawyer to the stage, right? So Nisha Pasupuleti, you are a lawyer and a strategist working on strategic solutions, not only to dismantle structural racism, but I also noted in your bio that you formed and worked as a lead strategist on a medical legal partnership. So one of the things, as Dr. Smedley says, that is very unique about this gathering is the collaborative disciplines that are working to solve problems. Nisha, would you tell us the narrative of what brings you to the work, please?
How about now? Okay. So really my narrative is very personal. It's been a winding road to get here. So first I want to ask you all, what do you think about Flint, Michigan? What comes to mind when you hear Flint, Michigan? Water crisis, right? I'm actually from Flint, Michigan. I was raised there my entire life. My siblings and I are products of first generation. We're first generation to this country. I'm the first college graduate. I'm the first lawyer on both sides of my family. And frankly, a lot of my experiences were shaped where I was raised. And I was reflecting last night, thinking about Flint, Michigan, and for all intents and purposes, they still don't have clean water, and it's an infrastructure problem. We went round and round for years from 2014 to 2017, where everyone was placing blame, and finally a whistleblower was a clinician. A clinician actually said, there is not clean water here, and all of our public health crises, a lot of different conditions that emerge, were stemming from that crisis. And another thing that I was reflecting on, I'm also a twin, and my twin sister is a survivor of non-Hodgkin's lymphoma. She had stage 4 cancer. She had to drop out of medical school. I'm thankful to say that she actually is a practicing physician now. She has seen a lot through the pandemic, but she's also seen a lot of structural racism as her practicing medicine in a rural area. So a lot of these different factors shape how I view healthcare. And to me, it's everything but healthcare. You have to look at all the other drivers of health, the other determinants. And I just honestly think where I was raised is kind of what shaped where I am now.
So I'll tell you my strategy right from the start. You've now had introductions to the speakers, but you've also had introductions to what we define as structural racism. We have an agreement now as to what the problem is. My next set of questions is going to be about figuring out who the players are, those who are suffering and those who are responsible for the solution. So I'm going to start with you, going in reverse. I'd like to know what the root causes of structural racism are and who you identify as responsible for dismantling it.
I was reflecting on this as well, and I think back to a quote that I think we all know. Every system is perfectly designed for the outcomes that it achieves. Every system is perfectly designed for that outcome it achieves. So really, when we view healthcare, it's for our healthcare organization systems, and often the last person involved are our patients and communities and strategies. So really, I think the root of it is our infrastructure. It's all causes. We call them drivers of health, social determinants of health, but I'm often thinking about ride shares, food system strategies, everything but the actual healthcare. There's a long road that brings you to the ED, to seeing your physician, and it often isn't your health. So I think the structural issues really stem from basically our infrastructure.
Dr. Blackstock, root causes, who's being harmed and who's responsible for fixing it?
So I agree with Nisha in terms of systemic factors influencing health. But I think that there are other factors that reinforce those inequities. So, as a physician and someone who has been in academic medicine for most of my career, I also think that we have a problem with obviously not having a diverse workforce. We don't have a workforce that reflects our patient population. And we know from studies that racial concordance can improve health outcomes, especially for Black people and other people of color. And so, and I know Dr. Smedley mentioned this in his presentation, but there's so many different factors that we can use to improve that pipeline, to improve the diversity among the healthcare workforce. And then also, obviously, I do think that the structural factors, as you mentioned, I think about my upbringing. I grew up in Crown Heights, Brooklyn, And my parents purchased our home in 1977. And although redlining was outlawed then, by then, my parents still had a hard time purchasing our home because of the remnants of redlining and because our neighborhood had not been heavily invested in. And fast forward now, our neighborhood and others like it that have yet to be fully gentrified, we still see that connection between having the very worst racial health inequities in the city. And so thinking about how policies from the early 1900s are still impacting our communities today is something that we need to think about in terms of figuring out what the solutions are.
I love that you identified home ownership and that wealth gap, that difference that your family had to endure in order to become homeowners. Even the opposition that your mother got to the idea that she could be a physician and leave that legacy to you. So I'd like to know, if I may ask you, Aida, what role do physicians play, health providers play in dismantling structural racism?
So I'll just add one more thing to what was said is the reason why we are here, which I really like this health, this summit that we are here is the connectivity. As a physician scientist, I try to think always as bridges. So there is that, you have policy makers maybe far distant from the healthcare providers and patients. So how do we bring that closer, right? So as a healthcare providers also, for example, I can give some examples when you're, as a practicing physician, at the bedside, you're not thinking of those disparities. There is data. So as scientists, we know that data sits somewhere else. But when it comes to the practice, to the reality is, are we really using it to apply at the bedside in terms of how we care for that individual? So this is how I think always, like I think about this mistranslation or this broken bridge where you may have very good policy, but if it's not implemented at the bedside, or vice versa, where you have these barriers to the policy, but the patients are, as physicians, we cannot even, when you're making those calls, sometimes it's like the insurance, for example, just a simple example, because I treated chronic diseases, patients who would burn out through multiple therapies, is sometimes the policies are the patient has to fail drug X, Y, Z, or this kind of diagnostic tool before they get to the right one. So there are a lot of these things that we need to really, sometimes we need to work from the patient. Again, I ground ourselves where the patients are, that patient journey, and how could we really link. And that also is in my role, even in pharma, to try to think that way.
Can I add
Please
something
jump in,
just
yes.
from a physician perspective? So I would say very frankly that I think our medical education systems have really failed our students and trainees in terms of how we've been taught. I know that, and I'm working with schools now to correct that in terms of addressing the curriculum and in terms of addressing how our residents are trained. But the fact is that there's still a lot of opposition to even physicians, the vast majority of physicians understanding how racism impacts the social determinants of health, which leads to poor health outcomes. So there's this idea, and I don't think it's an idea that is extraordinary, but this idea of structural competence. So we talk about cultural competence, but this idea of healthcare practitioners, not just physicians, nurse practitioners, physicians assistants having structural competence. So understanding how there are factors further upstream than the social determinants of health, like our economic system, like systemic racism, that impact our social determinants of health, that then lead to the poor outcomes that we see today, and how, as a healthcare practitioner, you can integrate that into how you care for your patients. Because I do feel very, very deeply that it is our responsibility to think about what is happening in our patients' lives outside of those four walls of whatever clinic or emergency department that we are caring for our patients. If we're not, we are almost actively harming our patients.
I know someone is taking notes for the report, but you heard a number of solutions, a number of things that we can do in action, right? Aida was talking about the distance between the data and the physician's bedside experience. We have to find a way to bring those together. And then Uché says that the education system, the way in which we're educating our physicians, clinicians, practitioners, is not teaching them to account for the social determinants that they are dealing with, and it's almost malpractice, if I heard you correctly. So Nisha, could you give us some strategic ways in which we could bring data to the bedside, in which we could hold physicians and providers, clinicians accountable for the kinds of structures that are affecting their patient health?
Absolutely. So I think we all know good data is hard to come by in this industry, but data integrity and data validity is of utmost importance. It's very critical. And, you know, I immediately go to, are we properly collecting race, ethnicity, language data, sexual orientation, gender identity? If we're not even coding that appropriately, how are we taking care of our patients? And I'll give you a personal example. I directly went into my own electronic medical record. I was coded incorrectly for my own race and ethnicity. No one ever asked me. I guess I presented as a different ethnicity. We can't assume anything about our patients and our care. So, you know, to be frank, garbage in, garbage out. So even if we're coding it, what if I say, you know, John Doe is white, but then I'm also coding Jane Doe is Caucasian? We're not having the same fields. So I think we have to have a very robust data strategy. And, you know, I know we're all struggling with this, but if we don't do that, we're not actually impacting the populations we serve. Another example is if we don't know what's happening, for example, with a Latino population, I saw some in a previous organization, some data showing that we have an opportunity to address colorectal cancer and improve our screenings there with Latino men. But, you know, we kept looking at it. Why isn't anyone coming in? Why isn't anyone coming in? And really, it's simply because we didn't look at their schedules. We had to open another day of the week for them. They're working Monday through Friday. So if we're not even improving our access, knowing what we know about these demographics, we aren't hitting the mark, as Uché said. So I would definitely say that your data integrity strategy has to be first. It has to be correct data for us to even look at the opportunity.
And can I add something? I mean, we even saw that in the rollout, or just, you know, since the beginning of the pandemic, like not having race and ethnicity data or just that demographic data and not knowing, well, we know where to target the resources. So we know which communities have been chronically under-resourced, but we need that data to show where do we focus testing? Where do we focus vaccine outreach? If we don't have that data and we're not compelling organizations and localities and states to collect that data, then we are not going to be able to direct the interventions to the appropriate populations.
Beautiful. So we're talking about data integrity. And now I want to go back to you and ask you, Aida, can you talk a little bit more about practices that you have seen that are effective? Things that physicians, clinicians, and other scientists have done that you see that are working that you'd like to amplify and see expanded?
So I'll use the more recent one since the pandemic. We're still in the pandemic. And so I'll discuss maybe a little bit about the COVID-19 vaccine and what has been happening at Pfizer, because that's really one of the things that is really at the top of mind currently. And I think what I've seen happen is when the pandemic, there is a virus that everyone was focused on one goal, that the virus was the enemy. Then everybody in the organization faced and looked at what can we do. So, and I go back to my colleagues here who have worked on the multicultural health equity coalition for many years, in fact, through their work and through others, I mean, patient advocacy, in fact, to really meet, because traditionally and generally, clinical trials have not been diverse and still are not. But the COVID-19 vaccine, at least a third, 30% had diverse background, which was, and to do it in such a short period of time to be successful, it really needed these colleagues to be really involving, doing those outreach, and then reaching out to those sites. So it was really those efforts that led in such an unprecedented time, because you can have a very effective and novel therapy, but you also have to really be inclusive in that research and development. Certainly it doesn't end there. We know that vaccines have to translate to vaccination. And still this group, in fact, is working with many communities. And if I encourage you to read the aviso that you have in front of you, and there is a lot there that is showing in terms how they are participating, because the important one also is, I go back again to the patient, is to have that community partnership, because that's where the underserved communities are, because that is where, as we heard, the COVID-19 pandemic disproportionately impact underserved and minority population. It's not news to anyone who's worked in this field because we have seen disparity has existed in that population. But the solution is that because we declared it as a pandemic, and I do feel disparities, health inequity should be declared as a pandemic, and we should all, it's not about competition. It is about all of us. And I usually say that health equity should not be sitting in a separate place. It should be embedded in everything we do. It should be part of the business. And so I think because then it makes it also, in fact, it's easier because it's your business. If you have that equity lens, you're not veering off of what you do in your everyday today work. It becomes part of that fabric. And I think then it involves everyone because it's such a layered, it's almost like a domino, right? If I am a physician, as a CMO of Pfizer, whatever I did at Stanford, when I am seeing that patient, I need to embed that in what I do, and others. If everyone does that, I think this is how I feel we will find a solution.
Beautifully said. And I also heard, in addition to embedding and integrating health equity in all that we do, I heard the involvement of community, right? I think I heard that, and I want to give both Uché and Nisha an opportunity to speak about that. But I'm going to throw a monkey wrench. This wasn't in the list. So both of you have talked about the COVID pandemic and its disproportionate impact on African American, Native American, and Latino American communities. Washington Post just broke a story that told us that actually white populations are dying at a higher rate. Social determinants of health, social context, is racism still at the center of the pandemic? Shed some light for us on community involvement and the data we know about the pandemic particularly.
You know, I think about this, I'm going to share a story. It happened, it was December of last year. I was walking down the main drag in my neighborhood in Brooklyn, and I hear someone say, "Yo, Uché," and I turn around and it's my old barber. Like back when in my 20s, I used to wear my hair very, very short. So and we see each other often. His name is G. We see each other very, very often. And so he got out of his car and gave me this tight bear hug. He's like 6'5" guy, gave me this tight, warm bear hug. And I said, "What's going on?" He said, I said, "I need to talk to you." And I said, "About what?" And he said, "About the vaccine." And I said, "What's going on?" He said, "Well," he said, "I have a lot of questions." And I said, "Okay, let's find some time to talk about it." So we made time for a call the following week. And I took a call with him and his adult daughter, who they both had not yet been vaccinated. And this was December of 2021. And he said, "You know, you are the only doctor I know." He says, I don't have health insurance. I don't have my own doctor." And he said, "And you're the only one I trust." And so we stayed on the phone for about an hour. And I answered the most thoughtful questions from him. And I thought to myself, can you imagine if every person in my community had a Dr. Blackstock, not saying there's something special about me, but had someone that they could trust to ask their concerns, to answer their concerns, and then also obviously the access to healthcare. And that's why I think it's so important. The community voice is so incredibly important. He told me, he said, "You know, I hear Dr. Fauci, you know, on air, but I trust you." You know, and that just hit home to me. And I said, you know, there's the importance of, and we've seen so much success during the pandemic in community-led efforts. I think we truly need to center the community's voices because there are groups that are already doing some amazing, amazing work. They're already embedded in the community. They are trusted messengers. They just don't have the funding and the resources. And so I think that story just exemplified to me the importance of really reaching out to our communities, engaging with our communities, and any high-level work that's done has to ultimately trickle down to centering communities and the voices of those people.
Now, please. I don't want to lose track of the other drop the mic thing that you said. It was not only that communities need to be involved, but that bear hug came because your barber knew one Dr. Blackstock and one person that looked like him that he could see walking down the street in his neighborhood and that he could trust. Dr. Fauci notwithstanding, the declaration of the CDC notwithstanding, all the work in the research notwithstanding, he had. So I don't want to lose sight of workforce diversity and how important that is, and how access will not really mean access until there are more Dr. Blackstocks, right? So tell us about the strategies that we have to employ that either are working. I'm going to pivot a little bit now to the ones that you want to see. Solutions, action steps, interventions that either are working and you want to see amplified, Nisha, or that we ought to be doing more with.
So I just recently gave a panel talk for a whole room full of strategists, you know, top of their game in healthcare across the industry. And I asked a simple question. I just said, raise your hand if you have a health equity strategy embedded in your overall strategy for your organization. How many people raise their hand? No, one in a room full of strategists. My jaw dropped. And I think it's the utmost importance. It has to be part of your overall strategy. But, you know, we'd be remiss to not think about the other factors. You know, there's no secret here. There's a deep distrust in minority communities for the healthcare system. This is long-standing, decades long. You know, from the Tuskegee experiments on, we've seen a lot of different issues. So there's a deep distrust there. So I think you have to pivot in your strategy, and it's really presumptuous to think that we know what our patients and communities need. We need to hear from them. And what strategy I really found that worked for my groups in the pandemic was a robust messaging framework. So, you know, you can have fancy pamphlets, you can have the best marketing materials. It can be perfectly translated in Spanish or whatever your community is. Is it in the vernacular of what your community is talking? Is it, would you put that in the barber shop? Would it be how your community is talking? And I'll never forget this. We spoke to someone in Rochester, New York, a real just trailblazer during the pandemic, got just amazing vaccination rates in the Black community. We asked, how did you do it? And she goes, oh, it was really simple. I went on the local radio station. You know, that's going to beat a fancy strategy every single time. You have to go where your community is. So really, I think it's the simplest strategy that we need to deploy. But first and forefront, if you don't have a health equity strategy, you're missing the mark. It's too late. It should be from data, your clinicians, your training, all the way to clinical protocols and your workflows to the actual patient. It should be all the way throughout. Some innovative models that I found to be successful, a medical legal partnership. I don't know how many of you are familiar with this concept, but the most basic example is, you know, little Tommy presents the ED with mom, you know, experiencing asthma. I had childhood asthma. I understand, you know, you really can't breathe, but, you know, keep talking. It's actually a landlord-tenant issue. There's mold in their apartment. So, you know, these innovative frameworks where it's too late once they come to see the doctor. It's too late if they hit your ED. It should be more about, you know, do they have the supportive services around them? Another model I've heard is really successful is a medical financial partnership. Budgeting, you know, very simple things. Do you even understand your healthcare deductible? Do you understand insurance? What are your wraparound services? The very basics, you know, I think we're discounting how intergenerational wealth has perpetuated a lot of these racial structures. So if we get even the basics like that, legal issues, you know, political drivers, and I know we have an expert here talking about that later on with us, but all those factors embed into your strategy where it should be simple, listening to your community, and actually starting before it becomes a healthcare issue.
And can I just add, what Nisha's talking about, like that is structural competence. That is something that every healthcare professional should know. So even if a patient is being seen, the healthcare professional should be screening for this, right? Or even it could be screened at the front desk in a checklist if there are any issues of food insecurity, housing insecurity. And so that should be within our scope of practice and within our domain. And can I just add that a lot of these, I think, are not new ideas. So I have to talk about, obviously, the Black Panthers. The Black Panthers were practicing structural competence and health equity way before health equity became, you know, an expression, right? They had free food giveaways. They connected people with legal assistance. They provided transportations for families to see their loved ones in prison. They performed sickle cell testing and even some research, right? So community groups have been doing this for a very long time. So there's, you know, no sense in reinventing the wheel, but I definitely wanted to make sure that we give, you know, recognition to where the work has really started. Can I just add that there is a story of a success. So the Roots Birthing Center in Minneapolis.
Could you say that again?
The Roots Birthing Center in Minneapolis, they are a mostly midwives and doula. They are a Black-owned birthing center, and essentially they have shown very wonderful outcomes. So they have very few preterm births, very low C-section rate, but their model is essentially to honor the humanity and dignity of Black birthing people. Right. And so thinking about how that model could be replicated across the country. And so it's a great study on this birthing center. They've received a lot of press, but that's something that could be replicated other places.
Modeling humanity, respecting and honoring the humanity of human beings. My last question before I go to audience questions is going to be, what does success look like? And I'm going to start with you, but let me I cannot let that just not hang in the air a little bit longer. We are talking about solutions that some are innovative, but some have been around for as long as the Black Panthers, right? We don't lack a list of things to do. We don't lack a list of action items. We don't even lack the data that tells us that many of these will work. Since the IOM report in 2003, we have been documenting these disparities. Thank you, Dr. Smedley. Thanks to the National Minority Quality Health Forum, we have been data-driven, evidence-based, recording what will work. We lack the political will to do what actually needs to be done. So I'm going to join Congressman Kelly and say, not only vote, but drag everybody that fogs a mirror with you to vote this coming November. What have you seen that works? What does success look like? That's my last question for each member of the panel. What does success look like?
So I'll take the pharma perspective because that's the role that I'm playing. I think I go back to the COVID-19 vaccine, how in terms of inclusivity in research and development, I think that is important because it gives access to information, innovative medicines. And I think it is because that builds trust and confidence. So I think we need to move from how do we implement the things that worked, because there are many chronic diseases, many other issues that we really need to tackle. So I think this is important. And there are some things that we are trying to do at Pfizer, for example, end-to-end, starting from the concepts. Let's look even at our biobank. The biobanks, the research that we use actually are not diverse. They are homogeneous. We use the Uché biobank. We use the Helsinki. But we don't have a diverse population when it comes even to our early research. So how do we do that? And we have started, in fact, a new initiative that was launched in November of 2021 called Institute of Translational Equitable Medicine, moving on to our clinical trial diversity initiative, to our multi-health equity collective that we just heard. They are the experts, Nisha and Melissa, who have been really pioneering this at Pfizer, our patient advocacy, and all the way also into our medicines, making them accessible, which was Pfizer recently also. I have to take also that global because I come from those sub-Saharan Africa, is the Accord for Healthier Award. So I'm also a board member for Pfizer Foundation. So those are the things that, but I cannot underscore the need to really partner with those communities for which we are serving and solving this.
Thank you so much. What does success look like to you, Uché?
It sounds simple, but it's not. But it's improving the quality of life for Black, Latinx, and Indigenous people in this country and closing those racial health gaps. I mean, I think the study just came out, I think earlier this week, that showed the pandemic essentially accelerated the maternal mortality rate. You know, and with Black women, or Black pregnant people rather, being most disproportionately impacted. And this is despite innovations in technology, right, research. We're still seeing these gaps widen, right? And so this understanding that health is not just health, but health is improving the overall quality of life, right? So I think that requires significant investments from both public and private sources to reinvest in communities that have been deprived of resources chronically for such a long time. And thinking about all of the levels of intervention that could be done on an interpersonal level, that could be done at an institutional and organizational level, at the systems level, but thinking about all the areas that we could embed health equity in it so that people people that look like me, that look like my mother, my family, can lead long, fruitful lives.
Very good. Did you want to add? Yeah.
To your point, I think this is a very important one. I think there is data, in fact, recently, because to your point about innovation, when we look at breast cancer, actually we're doing better nationally. It showed, in fact, there is an improved, but the disparity remains. But we haven't really made that needle hasn't moved for the underserved and minority Black women. It hasn't changed. So your point is really a critical one. Thank you for bringing that up.
We can move the needle, however. This can be done. Nisha, what does success look like to you?
You know, I think we've moved to a point in our industry where healthcare is more viewed as a business than providing care to our patients and communities. So success to me is really simple. I'm going to double down on the provider diversity strategy. You know, I think about my twin sister every day. I know we have a hard last name. It's really difficult to pronounce, but she's often presented to her patients as, this is Uché. They don't say who she is in the care team, anything like that. And I was recently reflecting on the Game of Thrones or House of Dragon phenomenon. And we hear about all these complex names that are made up, you know, Targaryen, you know, they speak Valyrian, they, you know, I don't even know, right? But if you can pronounce Targaryen, why can't you pronounce your provider's name? And that dignity should be showed on the other side to the patient as well as the community. And just again, on the patient side, simple strategies, just like meeting them where they are. So if we're talking about food systems and nutrition, you know, it's really presumptuous to think that your outlook on what culturally acceptable food is fits into their idea. So protein might look different for someone in Asia versus Western America. So do you give different options about what that looks like? So health literacy, health, you know, how we even view our care has to change. So to me, it's both sides, the diversity for our provider, acknowledging our diversity for our patients and communities.
So you've heard here, you think I can see that? I can't see that. Somebody has to read that to me. I'm done? Q&A, yes. Okay, Q&A. Thank you very much. All right, I'm going to do the dignity of asking Nisha Pasupuleti, Uché Blackstock, and Aida Habtezion to answer questions from the audience, please. Somebody else is going to have to walk around with the mic because you've already discerned I can't see, right? Okay. I see one hand here. Yes, sir.
Hi, I'm Reggie Tucker-Seeley from Zero Prostate. Do I need the mic?
Are we recording? Does anybody need a mic?
Probably,
Yeah, okay.
Hello, I'm Reggie Tucker-Seeley from Zero, the End of Prostate Cancer. Is it on?
I don't think so.
Okay. And I think the last 4 to 7 years have shown us the sizable population that subscribes to white supremacy. And so what I'm seeing in my work is what I'm calling health equity fatigue. People saying we're still talking about this issue. So how to battle that both within our organizations and sort of outside of our organizations. And the second notion is this subscription to a zero-sum game in this process where many in the white community may feel like they have to give something up in order for us to erase the disparities that we see.
Dr. Blackstock?
Oh, that's right.
Fatigue.
No, fatigue. Actually, can I answer the second part? No, because it touches upon the Washington Post article that you mentioned. And like we've seen life expectancy declines over the last few years. Obviously, they've been mostly among people of color, but also among white Americans. So this idea that you're willing to risk your own health because you don't want people of color to benefit from policies that could help everybody. I mean, I think that we are in such a dire situation right now. And I'm hoping that some of the solutions that we talked about today can give us some hope in that. But I also kind of am sitting with that and trying to hold space for all of that, because it's a lot that people would actually risk their own well-being so that, you know, Medicaid expansion, for example, doesn't happen. In terms of the equity fatigue, I mean, you know, with my organization, Advancing Health Equity, we work with healthcare organizations to create more equitable workplaces. And we have seen sort of a change in sort of requests for our service.